And you suggested that I started this project about a year ago. It's not quite right. It's about 37 years ago. I've been working on what I hope to deliver today, bringing it up to date, trying to make it as current as possible. And let me just say a few words on why 37 years ago, because there were a few incidents that happened to me very soon after I graduated that in many ways shaped everything I've done since then. And that tends to happen in life. I recently graduated and my late father developed prostatitis, running a high temperature, and then being unable to pass urine, bladder swelling up, great pain. The obvious thing to do is to rush him off to hospital. No, I was sufficiently an idiot in those days to think, well, I'll have a go. I'd read on what to do. I'd never seen it done, but I thought, well, let's try before we rush him off to hospital. Which I did, in terms of osteopathic treatment, and one or two other things, including a hot bath, which was very important to relax the urethral sphincter. And he got over it. He got through it within a week. I then had to justify it to myself. I then had to justify what I did to my mother and the risks that I may have taken. The next incident was again with my father. About a year later, he suffered a myocardial infarct. No mucking about this time. Rushed off to the Royal Free because we lived in West Hampstead. But I accompanied him in the ambulance to the hospital. And he's in the emergency room. The doctor on duty was examining him. Thought that it wasn't a gross myocardial infarct, it was a minor one, but wanted to keep him in hospital. They hadn't found a bed for him yet on the appropriate ward, and I turned to the young doctor and said, look, I'm an osteopath. I think I may be able to help him. And he turned around to me and said, what do you mean? What are you going to do? And I had to find a sufficiently convincing answer in one or two sentences to persuade a competent medical graduate in charge of my father that what I was going to do wasn't going to hurt him, make him worse, and may help him. And to my amazement, absolute amazement, I'm sure it wasn't legal, he said, go ahead, have a go. The third incident was about 6 months later. I'm now into my year and 3/4 after graduation, just approaching the second year. And this was a student, I'd already started teaching, and this was a student whose wife was, in those days, a senior operating nurse, and was in her final stages of labour in the West London hospital, but had gone into pre-eclampsia, blood pressure shooting up. They, for some reason, her more than he, called me by phone and said, would you come round to the hospital as quickly as possible and see if you can help? Because she's already started medication and it wasn't working. Or it wasn't working sufficiently. And they didn't want to pump more and more medication to bring down the blood pressure, given the condition that she was in and danger to the fetus. I came in, and once again, I had to find the appropriate words to convince the duty medical officer in the obstetrics ward to allow me to put my hands on this highly vulnerable patient and see if I can help her in this very vulnerable medical condition. Luckily, she responded, not just to me. I was able to employ the student who already had learned two-man techniques, which were essential to get the appropriate leverages to bring about something sufficiently powerful and yet safe to have had an effect. It didn't work on the first treatment. It took 3 treatments in the course of about 7 hours at the bedside, each treatment lasting no more than 5 or 6 minutes, to get the blood pressure to come down, to the amazement of the duty officer, obviously. But I had to find the appropriate words. I had to find something that registered in his mind medically as sensible. The 4th incident becomes very much more personal in some ways. And this concerns a girl, a young lady I was very fond of and very keen to get to know very well. And we were getting on very well until she mentioned what my profession was to her family. Her family being parents who were both GPs, all 3 brothers who were all physicians, and an uncle and an aunt who were physicians. The whole family were in the medical profession. And in those days, 35 odd years ago, osteopathy was almost a dirty word amongst the medical profession. It was quackery. And they obviously put some kind of pressure on her that maybe I wasn't very appropriate for her. And it really jeopardized our relationship. Funnily enough, about 10 years later, I tried to stay in contact with her. She didn't marry, and it was still a potential. About 10 years later, I happened to write a letter, a long letter, to one of the medical journals that was a GP publication, about the value of thinking carefully about the position in which birth should take place to ease the birth process, and how unnatural most of the positions used in obstetric hospitals were. And I had also developed a birth stool. That's a story in its own right. I wrote this letter, it was published, and her father and mother read the letter. The irony is, they said, "Oh, isn't this your friend? Oh, he's quite intelligent. He's got some interesting things to say." And it did change things for a short while. Then last but not least, and it brings us very much up to date, the past 20 years, I'd spent half my working week for 20 years while living in Israel in hospital practice. First in Jerusalem, now when we moved north, in the major hospital in the north. You can't go into a hospital department when you're not a doctor or a nurse without having to continuously justify yourself. Continuously have to explain why you're doing what you're doing and what you think you're going to gain by it. So that's very much the background to the time and effort I put in to try to summarize what it is we do and why we do it. Both to justify what I do to myself when facing acute patients, sick patients, and to my colleagues, and to my mother-in-law, and my sister-in-law. The joke is that my son recently fell seriously ill with influenza. He caught it from me. I had it very mildly. He got it very badly, and he wasn't getting better quickly. And mother-in-law's in the background, and my sister-in-law's in the background, saying, "Surely you should take him to the doctor. Surely he should be on medication." Forgetting that most influenza is viral, and you may get a secondary opportunist infection, but it's self-limiting, certainly at his age, and certainly as a healthy young man. There they are, mother-in-law, and says, I have to find a way of explaining to them, which isn't too medically jargon, but still one that can get through. It didn't work. It never works with your own closest individuals, as it may to strangers. So that's very much the background. I have a very strong suggestion. I mean, you're very brave to come, as Henry suggested, to a lecture that's entitled, that long expression up on the screen there. And not only that, it's on a Friday, a working day, so I do admire you turning up. And you're going to have to look at my face for about 6 hours if you include the lunch break. It's about 6 hours of lecturing, so it's admirable, and I hope I can keep your attention. But I have one strong word of advice. Obviously, what I'm going to present at times will be pretty heavy and detailed, despite my attempts to make it as simple as possible. You cannot possibly take it in all in one go. You can't. However, the whole of this lecture will be available, hopefully on iTunes. You can just click into it and hear it all over again, and slow down and see it again, and stop wherever you want, and literally see it all properly in your own time and think it over in your own time. So what I'm going to suggest you to do is sit back, enjoy what you can from it, relax, don't try to take it in, because then you'll probably miss what I'm trying to say. Just see the nice pictures and hear the nice thoughts. In your own time, look it again and criticize it, tear it to pieces and do what you like. But make it an easy day for yourself, despite the title. Okay, what I'd like to do to start off with, can you hear me clearly now? Better probably, I can also, that was my voice for 6 hours. Let me just run through what it is I'd like to cover in the course of the day. Ideally, we may not be able to, but I'll try. The agenda for today. We'll start off with Still's fundamental premises. What were the fundamental premises that Still based his whole life's work on? What's the research evidence that's available regarding their validity? How do we translate that at the hospital and home bedside of the acute patient? Things that some of you may never have seen. We'll try to look at the clinical and palpation characteristics of somatic dysfunction and of the underlying inflammatory processes. What are the clinical and palpation characteristics? We're going to try to understand the significance of neuro and microvascular compromise and the role that osteopathic treatment and passive movement has in its treatment. I'll take you right back to 1903-4, when it first began, the early osteopathic research. We're going to look at some slides of clinical biopsies done in those days and perhaps be amazed at how they already recognize the factors that I'll talk about in more detail in terms of current research, the influence that somatic dysfunction has on vasomotor dysregulation. We're going to look at the dysregulation of neurotrophic supply, something that's as up-to-date as you can get in modern physiology, neurotrophicity. We're going to look at the role of facilitation, central sensitization, and the unique role of the spinal grey cord cells. We'll take a quick look, because of my work the past 10 years almost in a pain unit, at the pharmacological management of pain relief and ask ourselves, are we competitors or allies? Or are they competitors or are they allies? We're going to look at something that is still, I think, remarkable and still not sufficiently appreciated by most students of osteopathy, that the immune system is innovated. The immune system is innovated. And look at current research findings in that field. We must have a look at the physiology of pain transmission and try to bring it up to date. We've all had some instruction in that in your courses, but for some of us it's way out of date and some of us forgotten what it was all about. And I'll try to make it clear to you how manually, via these pathways, pain pathways, we can induce analgesia, provide pain relief. I'm going to bring you right up to date in really the cutting edge of modern medical research and look at gene induction and the possible effect of osteopathic treatment on gene expression. Mind-blowing when I first began to read about it about 2 years ago. Look at the latest research findings that suggest strongly that if you do the work properly, you're producing effects which are potentially mind-blowing. We're going to look at, and it's closely associated with how we produce gene induction, gene expression. We're going to look at a term called mechanotransduction, the role of fascia in relation to mechanotransduction, and the cellular mediated responses that follow putting your hands on the patient in an appropriately professional manner. We're going to look at nociception. We have to. It's our bread and butter. It's what we're dealing with day in, day out, hour after hour. And try to link it and look at the link with the limbic system and emotions. Almost to the end, we're going to look at the neuroendocrine immune response, the neuroendocrine immune response to pain, stress, and somatic dysfunction. And we'll round it out with a cup of tea. No, we'll round it off with a final look at the aims of osteopathic treatment. So you'll all be here till Monday morning. Let's kick off. Still's two fundamental principles. I'm sorry if one or two of you were at the lecture last night, but I'll be going through what we did last night rather more quickly. The rest of you, I think, are somewhat new. Still's two fundamental, you can sum up Still's work in two principles, I think. Maybe I'm wrong, but it took me a long time to see what they were and to summarize them in words that were appropriately short. And here they are. One, that there is often, not always, that there is often a somatic component to disease. I'll try to understand what that means in a moment. That there is often a somatic component to disease. Secondly, that the effective manual treatment of the somatic component may play a significant role in enhancing the body's immune response and recovery from disease. Still said that 120 and more years ago. In modern language, I use much more modern language than I use. Not that much more, because Littlejohn was already using the term immunity and immune response in 1902. I got clinical notes, teaching notes of his, given in Kirksville and then in Chicago. Probably given at the BSO, but no one listened to him. Using those terms. Immune response. We'll come to that later. Now, it took a little over a century until this appeared. No, a little under a century, not much, a little under a century. After Still founded the first osteopathic hospital for the British Medical Journal to see fit to publish in 1985 the results of an osteopathic trial regarding myocardial infarction. It confirmed the first of Still's fundamental premises, that there is often a somatic component to disease. Worth reading it thoroughly. You can still find it on the internet. 62 patients were randomized, a big number, 62 patients, a good statistical number, seen by 8 osteopathic physicians for palpation of the thoracic spine between T1 and T8. The 62 patients were divided up into 3 groups. 25 patients had confirmed myocardial infarction. Of the remainder, 22 were without cardiovascular disease. They acted as controls. And the remaining 15 were placed in an excluded group because they had a diagnosed cardiovascular problem other than myocardial infarction. Myocardial infarction group, control group without cardiovascular disease, and an excluded group that had cardiovascular disease but not MI. Examination of the group with MI, as well as the group with the other cardiovascular diseases, disclosed significantly higher incidence of soft tissue changes, confined almost entirely to the upper 4 thoracic levels, compared to the control group that didn't have cardiovascular disease, which was found to have a low incidence of palpable changes throughout the thoracic dorsum, uniformly distributed, where they did have somatic changes, between T1 and 8. What were these changes felt by the physicians? Changes that you all ought to be familiar with in your work with minor orthopedic problems. But if you look for them when your wife falls ill with a throat infection, or your child falls ill with influenza, or your grandfather falls ill with bronchitis, on your doorstep, in other words, you don't have to wait for patients in your office to turn up. You may well find the following changes, which they found, which are very familiar. Increased firmness, increased warmth, sort of roping feel, edematous changes, and a heavier musculature. You can do just that and pick up warmth. You can pick up stickiness, pseudomotor changes. Sticks there as well. You can pick up the ropiness. You can pick up the heavier musculature. Just that. We haven't even started moving the patient. You could have your names in the BMJ, don't you realise? Get 62 patients and just do that on all of them to determine something or other. Just be ready when you're ready. Of course, you'd expect that something like that coming out would have sent shockwaves through the British osteopathic profession and the schools of training. You would imagine there would have been a deep soul-searching going on. Why? For 4 decades, from the end of the Second World War, British osteopathy and its exponents, with a few brave exceptions, had all but abandoned the clinic and bedside treatment of the truly ill, confining itself instead to minor orthopedics, almost indistinguishable from chiropractors or physiotherapists trained in manipulation. BMJ. Students should have been up in arms, demanding reinstatement of osteopathic medicine, drawing on the texts, the wealth of texts that are available before they've been shredded, burnt, gathering dust in the British osteopathic colleges and the American hospital archives to understand the clinical data that was really developing in the earliest days and the treatment protocols. But you could have heard a pin drop. I was around then, 10 years into the field room. There's no dissension, no debate, no revision of college training, no single student dissertation that I remember, nor professional trial attempted to confirm or refute the BMJ findings. If the results of such further trials had confirmed the original finding regarding the existence of a somatic component of disease, it should have led to a profound, in my opinion, a profound reassessment of the value of the osteopathic profession. The medical profession would have valued us so much more. And it may have led to research into Still's second groundbreaking premise. That visceral and somatically related components of various diseases are to be regarded as integral parts of the pathophysiology and not to be ignored during the clinical management of the patient. Furthermore, as we've read already, that the effective manual treatment of the somatic component to disease may play a significant part in enhancing the body's immune response and recovery. It's taken a further 2 decades till this appeared. A second trial of the kind that was published in the BMJ, similar to the one in the BMJ, performed at the Texas College of Osteopathic Medicine just 3 or 4 years ago by one of the really great research workers in our field, Littlejohn, the man who put osteopathy back on the map 2 or 3 years ago with his meta-analysis, published widely in all the most respected journals, produced this study and is in the middle of doing it in a larger cohort of patients. A case-control study looking at the osteopathic palpatory findings in type 2 diabetes mellitus. The results, on 92 patients, very nice number statistically, were recruited, and the statistical finding was the consistent association of tissue changes at T11 and 12 on the right side. Now, Littlejohn went on to write another article in 2008, which I found remarkable when I first saw it. Here's the title. He went on to call on the osteopathic profession to rediscover the classic osteopathic literature in order to advance contemporary patient-orientated research. He suggested that osteopathic investigators would be well served to rediscover the classic osteopathic literature. Now, there has been a reflection on this call of his in that there are no growing number of trials conducted in recent years to investigate the possible effect of treatment of the somatic component of disease. Now, many of these trials are underpowered, and some of them have significant methodological problems, and one can query some of the methods they've employed, but they're often positive preliminary results, and the clinical implications of those results should once more have woken the profession up here in Britain. For example, in 2003, this trial came out in a very respected journal, Pediatrics, study of the positive effects of osteopathic treatment together with conventional treatment in children with recurrent acute otitis media. The results were very positive. And the suggestion is that it certainly should be investigated further because it may prevent or decrease the surgical intervention or antibiotic overuse. 2010, a randomized controlled trial was conducted to determine the efficacy of osteopathic treatment together with conventional treatment for hospitalized patients with pneumonia. Once again, beautifully large number of cohorts, 405. Only we could recruit 405 patients for some of the research we do. And the conclusions were statistically significant reductions in the length of stay of these patients, the duration of their intravenous antibiotics, and the numbers who suffered respiratory failure or death were less, statistically significantly less, in those that had, in addition, osteopathic treatment compared to those who didn't. So something's going on, potentially. We can turn our backs on it. We can ignore it. I've got a feeling that some of us may have a conscience if we do that. I've got a feeling some of us won't sleep quite so soundly. Some of us will feel rather bad if your nearest and dearest relatives go down with pneumonia. And you have to suppress what you may have heard today, you may have read, in regards to the possible way that we could help that grandfather, that father, who's gone down with bronchitis and pneumonia. What's actually done? What are the techniques being used? We're going to look at research done on animals that employed very similar techniques to the one I'm going to show in the following slides, just to show you that these are very practical measures. Yeah, that's good. Fine, thank you. Okay. This one was known as the osteopathic lifesaver. Literally. It was considered as important in those days as any physician today would consider antibiotics. We'll look at some research as to possibly why it was so effective. But it's not just a mobilization of the thoracic cage, but it also employs a pump mechanism. And again, if I just have a model for a moment, it's nothing that's too difficult to learn. It's nothing that couldn't be practiced by any recent graduate.
You would lie down?
Just lying down. You could keep your clothes on, keep your shoes on, don't worry. Take too long. just like that. You have to learn to work through pyjamas and through hospital bedclothes because the patient dare not get chilled. It's a considerable danger. The lower hand, if you look at the picture and look at me, the lower hand grasps the rib angles, taking the first five with the lower hand. The upper hand is directed over the second to the fourth or fifth, depending on the size of your hand, anterior aspects of the rib cage. The movement is one of disengagement of the rib angles and head laterally and superiorly with the lower hand, the upper hand applying a counter pressure depending on the timing of the movement. Just watch carefully. Not only are you mobilizing and springing the articulations, but you are also introducing, I don't know if you can see it, a pump, a vibratory pump. In other words, you take over the patient's breathing as you do this, and we'll look at what's going on physiologically in a few moments when the research trials done, when something similar to this was done on animals. To work further down the rib cage, the hands are changed, and you can easily slip from what you're doing now, which is mobilizing the thoracic cage and introducing a lymphatic pump, to then focusing on 7 to 9 ribs on the right and your anterior superior hand over the liver itself. You can easily move into what is known as the liver pump. And we'll look at that in some research that's being done recently as to its effects on the white blood cell count. It's done slowly, quietly. You have to be careful. You don't know what's under your hands until you apply the pressures. If there's any hepatomegaly, you go even more carefully. Watching the way some of my colleagues were drinking last night, I should imagine one has to go very carefully. Nothing difficult, but that was considered so important as to be called the osteopathic lifesaver because of the results, particularly in thoracic disease and pulmonary disease, but also in upper respiratory tract infections. It has a powerful effect. We'll see what kind of effect it has in a few moments. Sphenic pump. What I was doing to the liver, you couldn't do to the other side. Very effective. Spleen between your hands. Again, we'll put some research on that. Diaphragm. Extremely important in any attempt you're making in improving the immune response and the lymphatic circulation. Straightforward measures, if the patient's not too moribund, if they can hold you behind the back, very often they're too ill to do that. If they can, for 45 seconds to a minute and a half, then a very effective method is used to improve oxygen, carbon dioxide exchange, lymphatic flow, and venous return in the lung and abdominal fields. That's the beginning of the first stage of the maneuver, and that's the second stage where the diaphragm is domed as you encourage the expiratory stage of diaphragmatic excursion. Let me take you on to a home bedside case. This was a very sick lady, suffering acute bronchitis. Medical background is emphysema, chronic obstructive pulmonary disease. She very frequently suffers opportunist infection, bronchial opportunist infections, and sinusitis, which is very painful. And there I'm attending her at the bedside, where you have to employ approaches that adapt to the bedside. And we'll talk about that for a short while in a few minutes. But just take a look at the maneuver. You have to sit because the bed is too low to stand next to, otherwise you'll cripple your back. You have to be ready to adapt. That's a maneuver that takes both the spleen and the liver at the same time under your hands. It can be applied at the bedside and maybe one of the only maneuvers you can apply for technical reasons. In fever, in any rise of body temperature, it can only be 1 degree centigrade, and you've got to experience it yourself. There's particular hypersensitivity to all sorts of things. You all know that from your experience. Noise and light is the last things you want when you're feeling ill and you've got a temperature. Turn the lights down. You ask people not to make a noise when you retire to your bed. But you're also hypersensitive to any afferent input, including manual intervention. Your hands produce effects on a sick individual which you cannot produce on normal, healthy individuals, whose body dampens the afferent input automatically, naturally. This is an extremely important point I'm going to make. It is a totally different field, the field in which osteopathy was founded and developed for the first 50 years of its life, 70 years. The first 70 years of its existence, its work was on patients like this, and secondarily on minor orthopedic problems. If you read the protocols of the osteopathic hospitals, what were they treating? If you read the textbooks of the early osteopaths, what were they treating? Of course they treated back problems, of course they treated orthopedic problems, but the mass of their work was at the bedside as family physicians, or as hospital physicians. And that's what made the name of osteopathy. And they had the remarkable effects, I believe, that they reported, because when you treat, and I've only experienced that mainly in the hospital work I've done, when you treat the acute patient, even with an acute pain syndrome, it doesn't have to be a constitutional disease, the body is hypersensitive. It is primed. For good physiological reasons, we may look at them for one of those reasons is because when you're running a fever, the hypothalamic pituitary adrenal axis is working overtime. The locus coeruleus and the norepinephrine sympathetic center in the medulla is charged. There is, what you could say, sympathetic central facilitation. A priming response of the body results in hypersensitivity to all afferent stimuli. That includes upgraded nociceptor responses. If you touch the patient who's in pain, it's very easy to cause them more pain, because they are hypersensitive in this condition. But also, somatico-visceral reflexes are much more easily provoked, for better or for worse. Therefore, it's pretty logical that heavy treatment, or a heavy touch, is always contraindicated. Now, it's very rare that I use the word always, because there's so often exceptions in life. Nothing's black and white. But I'm sticking my neck out, I think, justifiably there, with that sentence, that heavy treatment, or a heavy touch, in the fever patient or the acute pain syndrome, is always contraindicated. You don't need to, and you should not use a heavy touch, because inevitably you'll make the patient worse if you do. The treatment has to be gentle, sedative, minimally invasive, analgesic, and of a very short exposure time to avoid exhausting the patient. You see, every treatment you give has to be incorporated by the patient. And to do so involves energy expenditure. And that's drawn from the body's reserves. Anything you do to the patient, even the bright lights and the loud noise incorporated by the patient, exhausts the patient, because in incorporating that afferent input, it requires drawing on limited energy reserves. So the treatment has to be short, precise, very controlled, watching the patient's response all the time to know when enough is enough. Back in 1998, a nice little trial was done. randomized pilot study on the effect of treatment, osteopathic treatment, on the length of hospitalization, pancreatitis, pretty serious disease, pancreatitis, showed a significant reduction of time of stay in the hospital. Those patients that received, in addition to osteopathic treatment, compared to those who received standard treatment alone. So osteopathic techniques in recent years have begun to be examined in regard to the treatment of infectious diseases, their use in infectious diseases, the treatment of infectious diseases, and using dogs as models. The irony is, this is almost exactly a century after similar trials in animals were done by the founder of the BSO, Littlejohn, by McConnell, his colleague, and subsequently Burns in both Kirksville and Chicago. The Journal of Lymphatic Research in Biology, a very respected journal, published in 2007 a study on dogs demonstrating the effect of the abdominal lymphatic pump that we just saw on a human patient to increase the thoracic duct lymph flow and leukocyte count. The lymphatic pump significantly increased both thoracic duct lymph flow and leukocyte count, so that lymph leukocyte flux was markedly enhanced. Increased mobilization of immune cells occurred, and is a likely and important mechanism responsible for the enhanced immunity and recovery from infection of patients treated with lymphatic pump treatment. There it is, both liver and spleen being pumped. So, shall we just look at that for a moment? Again, nothing difficult, nothing. In fact, this is one of the remarkable things when you look at the protocols of treatment done by the early osteopaths, by Littlejohn in particular, whose writings are so extensive. Don't worry about it. That the techniques used on critically ill patients were so simple. Once again, you try to take over the patient's breathing, asking them to let you take the pace and rhythm, short breathing gasps. Good. Thumbs directed inferiorly and laterally in the direction of both spleen and liver. The degree of depth is determined by the resistance under your hands. The rhythm is determined by the resistance under your hands. It's totally individual. You cannot define in advance either the depth or the rhythm to be used. It's entirely dependent upon the tissue yield under your fingers. A similar study on dogs in 2010, just last year, again published in this very respected biology journal, found that lymphatic pump treatment of the kind I was just doing also mobilizes leukocytes from the gut and the associated lymphatic tissue, or lymphoid tissue, and its movement into lymph. Similar results: increased leukocyte count, increased lymph flow, and probably provides one of the rationales behind its use to improve immune function in human patients. And there it is. There's a number of ways you can do it. Here I'm actually mobilizing articulating, you could say, the intestines. What are them? The intestines actually, if I'm not mistaken, contain something like 60% of the lymph nodes of the body, which makes sense because it's going to have to deal with a lot of proteins passing through the gut wall, many of them potentially dangerous, and has to be neutralized as quickly as possible. Remember the name of the lymph nodes in the gut? Yeah, Peyer's patches. Okay. Just one second. What does it look like? It's very beautiful. I think it's very beautiful. Has to relax, obviously. When they're ill, it's very easy. They usually are very relaxed and limp anyway. They can't be bothered to fight or to help. You can begin with a relatively superficial catching hold of the intestines between thumb and forefingers. And then you can work far more deeply. Working your way up from the sigmoid infection right across the transverse colon, right down to the ileocecal valve, depending on where you focus your pressures. Rhythmic, slowly. No drama, no sounds, no hoo-ha. Very quiet, very deliberate, very precise. Many of you are familiar with the thoracic pump technique. And there it is applied to a child. Now things change, treating a geriatric patient isn't the same as treating a young patient, isn't the same as treating an infant or a child. And here, the child, my son in this case, who was ill at that time, having a thoracic pump applied by having his thoracic spine up against my sternum, so that there's some solid base against which I can introduce the pressures on his anterior sternum, with underneath my fingers a major immune gland in the young child, that of the thymus. Literally pumping for a minute or two, which is a long time. Maybe the only thing you can do. And I teach parents how to do that. When I want the child to have a pump treatment perhaps every 6 or 10 hours, I can't keep going around necessarily to the patient's bedside if it's not a critically ill patient. So I teach the parents how to do this. And most can learn to do it well enough. There's the splenic pump on a child. Here I'm using the lounge table because it's more solid than the bed. It's easier for me to do the technique effectively that way. You have to find what's available. Contemporaries. Cranial technique. It's as old as osteopathy. Read Still's research and practice. The head was part of the body from the very beginning. It wasn't a decerebrated individual that the osteopaths were dealing with. And how else are you going to handle ear, eye, nose and throat infections? What are you going to do if you don't include the head? Well, there's a lot you do apart from the head, but the head is certainly considered part of the treatment, particularly if you want to gain some pain relief for the patient suffering from any infection of those parts that I just mentioned. And there's a drainage technique for the lymph around the sinuses, which is being employed in that picture. Continued over the nasen, down the nasal bridge, following the pathway of the lymph flow in the head and face to the angle of the jaw and down through the neck. Well thought out protocol, and you have to be able to apply it without breaks, without stopping, without necessarily jeopardizing the short period of time that you should be handling the patient who is acutely ill. In the course of the early years in osteopathy, it quickly became clear that there were certain areas that were not necessarily the direct neuro and anatomical connections to the viscera beneath, that time and again seemed to be dysfunctional, sensitive under the operator's hands. For example, 2 to 3C and 2 to 3T. 2 to 3C and 2 to 3T, 2 to 3T being the ciliospinal center, were important centres that time and again cropped up in eye infections. Now this is a technique that's Andrew Taylor Still. It's straight out of Andrew Taylor Still textbooks. It's called the switch technique, the spinal switch technique. The child is traditionally placed over, the young child is small enough, is traditionally placed over the operator's knees for almost all the treatment. And here the two legs are being used as a lever against the fulcrum hand applied across the spinous process of T3 or 4 in that case. My child had bronchial infection. It was an area of considerable concern for treatment. That's one of the most powerful techniques we have in osteopathy. We're using two legs as levers at the same time. So you have power without applying muscular strength. You can do that and yet not provoke pain. Whereas if you try to introduce the same forces with your hands directly and a short lever, it will produce terrible pain and danger. That's the great advantage, one of the great advantages of using long levers. Time and again, the second to the fourth thoracic was found to be particularly important in trying to affect deep and superficial circulations. For example, in the child with bronchitis or pneumonia, you're having to deal with hyperemia in the pulmonary field during the infection, during the inflammatory stage. And if you can introduce treatment that somehow manages to improve the blood flow because you're drawing hyperemia to surface cutaneous vessels, which are relatively anemic when there's a hyperemia in the anastomotic deep vessels, then you can introduce, at least for some hours afterwards, as a consequence of the treatment, a very rapid circulatory flow, which may be very useful in the treatment of bowel infection. There's a lymphatic jump on it in the child. Back to the acute patient adaptation. You may only be able to employ this particular technique where you have to sit by the bedside because the bed's too low, cripple your back if you try to do it in another way, or your knees, and just introduce, just in inverted commas, because it's a very valuable maneuver, deep, slow inhibition of the erector spinae, where you find the somatic component of that condition, if you can. It's a very important part of your attempt to modify these somatico-visceral reflexes that may be playing a part in slowing down the recovery of that patient from that condition. Now, we're not curing disease by doing that. We're just providing slightly better physiological conditions for the body's self-reparative mechanisms to work. That's all we're able to do. And we're very lucky because most of the time, almost always, of course there are exceptions, but most of the time, we're treating self-limiting conditions where good nursing alone would be sufficient for most of the patients to get better in time, which is what most physicians are doing. We're not in emergency medicine. Most of the time, the physician's job is to palliate the symptoms that are unpleasant for the patient and see the patient through a critical period. But most of the illnesses that are seen by a physician are self-limiting. They would get better anyway in time under good nursing. So don't be too worried, don't be too scared about taking on these conditions. You're there to make life a bit easier for the patient during the course of that illness, to run that course a little more quickly perhaps, or a little more efficiently, so that the illness doesn't come back in a couple of months' time. So that they're not quite as prone to the illness a little later in the year. So the role we have is modest. We're just there to support the reparative processes that are going on anyway. We're just there to boost the immune response a little more if we can, or to make it a little easier for the immune response to work by reducing any somatico-visceral reflexes that may be present as best we can. The great problem with treating the bedside patient is, of course, the softness of the bed. You do a lymphatic pump, and the whole patient goes down with your hands into the mattress. It's very frustrating. So from very early on, osteopathic techniques were developed where the patient is drawn off the patient's head is there. The patient is drawn, the upper trunk is drawn off the bed onto the operator's knees, the operator sitting next to the patient's bed, the cushion under the patient's upper trunk and head. And so your knees act as a substitute treatment table, solidity of your legs. Simple when you think about it, but it took a little bit of inspiration to think how does one do it? How can one make a treatment effective by giving some solid support underneath? Not with a plank of wood that you carry around with you on any home visit, just your legs, your own body. Just as the child couldn't be treated effectively with a thoracic pump in his bed, the child had to be brought to your sternum to provide a solid support against which you could apply the pressures over their chest, so that there was something to work against. We take this for granted, but just imagine the situation of the early osteopaths going to the home bedside and trying to apply maneuvers without having thought about these particular variations on technique. You may only be able to apply a side-laying maneuver. The patient's bed is up against a wall, soft bed. It's too ill to take them off the bed, but you can give a whole treatment in the side-lying position, a whole treatment including the neck. And the side-lying position happens to be the most valuable position anatomically to relax the erector spinae. The erector spinae are most relaxed, it seems, in the side-lying position. So your fingers can get in far more deeply in the side-lying position, particularly with an arm leverage. And you may have to work out a complete treatment in the side-lying position and on one side, because if the patient's bed's up against the wall and they're too ill to keep being turned around to get to the other side of the patient, you're going to have to think, well, how do I reach the inferior erector spinae without turning the patient over? So you have to have a wide range, wide knowledge of osteopathic techniques to be able to be ready perhaps once a year to employ that technique, because that's when that patient will require that technique. You've got to think on your feet. You've got to be very adaptable, whether it's in the hospital or whether it's in the home bedside or whether it's in the office for that matter. Many patients come in and cannot lie down. They're in too much pain. Whether it's a cervicalgia or whether it's because they've got a cardiac condition that doesn't allow them to lie completely flat, or whether it's, you all know, the late stage of pregnancy and the mother can't lie on her tummy and may not even be able to lie on her side because she's got sexual ileitis. It's too painful. You may have to give a complete treatment in the sitting position, particularly in the last stages of pregnancy. If you're accompanying a patient to the delivery, which some patients would be very grateful for you to do, if you're ready to do osteopathic obstetrics. I mean, not to deliver the child, that's the midwife's skills, but to be there to control pain and to ease the process. And you're going to have to work out, how can I treat the mother who would prefer not to lie down, but is very tired? You have to learn how to do it, literally, with just an ordinary chair. One chair. And you can do a complete treatment with the mother sitting astride the chair, arms on the back of the chair, head resting on their arms, and you've got the whole spine available for them. And all sorts of articulatory moves and inhibitory moves. Again, certain centres kept cropping up, for example, in respiratory disease in relation to 2 to 17. All sorts of manoeuvres. Again, you have to be ready for anything and everything. If you can't get the patient to lie down comfortably, then you have to do everything sitting. And this was considered right from the early days as one of the most powerful and effective ways of affecting the sympathetic ganglionic chain. If we had time, we could look at the anatomy that's being affected by this position, in the sitting position, raising the arm as a lever with your hand beneath the rib angle or above the rib angle. And the powerful stretching forces that you're introducing to the myofascial structures attached to the rib and running around and within which the sympathetic ganglia are housed. I'm giving away certain things that I'm going to talk about much more in detail later in the course of this day. You cannot use high velocity thrusts on a sick or acute patient. If you do, you'll either kill them or injure them, or never be allowed in the hospital department again. It doesn't work. And they never used it in the early days. If you read the texts again, this was one of the classic ways, and I'll show you a picture of 1906 when was still teaching at Kirksville, and one of his students called Murray demonstrating this particular technique. And it's what Littlejohn taught for years. And it's powerful, and it's effective, even more so when it's an acute patient. And it's precise, and it's beautiful to watch, and it's silent, and it's undramatic. And the most frightened little lady coming in with a cervicalgia will let you get on with the job. Because for the first few seconds she realizes you're not going to do anything frightening to her, or potentially dangerous. And the little child will let you get on with the job, who comes in with a torticollis and is petrified of being touched. Well, maybe not straight away, but sooner rather than later. And you may have to do this technique in the sitting position, because the patient can't lie down, it's too painful, or too frightened, or the child in particular doesn't want to lie down because they're scared that you're going to do them. So you may have to do this in the standing sitting position. The anterior throat is frequently having to be treated in any upper respiratory tract infection. All the myofascial structures that run, through which run every single lymphatic vessel, every single venous vessel, involved in the inflammatory response to that infection. You think what's under your fingers. When you relax the sternomastoid, you're in direct relationship to the vagus and the cervical sympathetic ganglia. It's right there, millimeters away from your fingertips. You'll see in a few moments pictures actually putting hands on the vagus and on the superior cervical ganglia as part of the osteopathic treatment. 1906, I'll show you the pictures. And here, we're talking about a very sick, potentially, he was just modeling for that at that moment, a very sick patient who cannot be turned, cannot be moved, perhaps has lifelines and drips next to them in the hospital, and this might be all you can do. You want to reach the segmentally related soma. Could be a kidney infection, for example, or the pancreatitis research that we looked at earlier. Make sure you know your applied anatomy. Get your hands on the erector spinae on both sides. Your fingertips virtually touching the SP is between. You're going to draw the erector spinae laterally as you lift so that the weight of the patient is doing the work for you. I mean, you're doing half of the work yourself, but literally the weight of the patient is drawing aside the erector spine. I wish all my patients were his size and weight. Absolute joy. Powerful. It's not tickling you.
It's very relaxing.
And very relaxing. But you, the operator, sweat. It is work. It is work. It's the whole hand, of course. It's not little fingertips causing pain. It's the whole flat of the hand, with just the last bits being applied as pressure points.